So coming up next is our next speaker, Dr. Preeti Paritosh Kamdar from Mumbai, a dynamic young lady who's going to speak to us on progression in glaucoma, the challenge accepted. Dr. Preeti.
Good afternoon, everyone, and I thank AIOC for this opportunity. Now, determining if a patient's glaucoma is stable or not is one of the most frequent analyses we perform in our clinics, and believe me, it's a challenge. Arriving at the correct answer is important because failure to recognize progression is like one step towards blindness. And conversely, incorrect diagnosis of progression can lead to decisions involving even surgery. So, at present, there is no single modality which can give us progression on its own, and hence we need all the information we can get. The key to detecting progression is establishing a good baseline at diagnosis, and that is done by recording all this, which we usually do. You have to remember that vision in early and moderate glaucoma is a very poor indicator of progression. So what we have here is these are the methods available: disc, perimetry, OCT, gonioscopy. This is just an overview in 6 minutes. How we detect progression in gonioscopy is what I'm not going to talk about in this talk. But what you have to remember is that the sensitivity of each is different across the disease spectrum. That you cannot use each in all levels of glaucoma. So what does it mean? So what are the general principles? That if you have pre-perimetric glaucoma and early glaucoma, disc photographs, OCT and fields, all three show excellent sensitivity. If you have moderate glaucoma, the disc may be damaged to an extent where it may not be sensitive. And in advanced glaucoma, OCT, disc photographs, they are all useless. Perimetry is the only thing which you have to assess progression, and that along with vision and intraocular pressure monitoring would give you a good idea whether the patient is progressing or no. When we come to the discs as a method of detecting progression, so this is the disc of this person in 2015. She underwent iridotomy elsewhere, which was not very well done, and the IOP remained high persistently after iridotomy, and this is the change. Now this is very subtle. Using COVID as an excuse, she did not come to me for 2 years. So this is 2017, 20 till 2019, the disc was exactly like this, and this is what happened in Jan 2022. Now this does not require disc photographs. It's in your face, this kind of progression. But there is a different kind of progression where now this is a large disc with a large cup disc ratio. This is taken in 2013 and this is 2019. There is a very subtle difference, and this is progression. Mind you, the pressure was always borderline. The fields are even normal now, but I know that this is progressing. No amount of good disc diagrams will tell you this for sure. So disc photographs are very useful in detecting progression. Most patients, most clinics, they have OCT and they have perimetry, but they don't have good instrumentation for disc photographs, and it pays rich dividends. However, when in advanced glaucoma, as I said, when there is a complete optic nerve damage, they are of no use in diagnosing progression. However, I have to tell you that this requires a kind of discipline, that no matter whether you feel that the person is progressing or not, take a disc photograph, and over the period of years you'll be able to detect progression in patients in whom the changes are very subtle and very slow. Now when you use OCT as to detect progression, so one is look at the right eye and the left eye. The right eye, it has reached a floor effect. Even if the patient progresses further, he keeps on losing fields further, this is not going to change. But if you look at the left eye, the superior RNFL is very robust and definitely can be used. And even in the inferior part, it has not yet reached its floor. Floor effect is the level at which any further damage will not cause any change into the RNFL. That's the floor effect. So the inferior part has not reached a floor effect. The superior is in fact normal. So in the same patient, you will use two different modalities to detect progression. In the right eye, OCT is useless. Mostly it's going to be perimetry. And in the left eye, yes, perimetry, OCT fields, all three. So now this is one gentleman who has ocular hypertension, pressures remained around 28, 29. If you see the inferior clock hour, it is 111 in this visit. After 6 months, it is 119, and after another 6 months is 103. So the question is, if you do not have too many, you just have 2-3 scans, how much change is significant? So because the resolution of these machines is 5 micron, ideally it should be 5 microns. But that's not what, you see 10 to 15 microns of progression, and it's not real progression. I have half a minute. Yeah. So this again, overview. I'm not going to go into the details of this, but when you have more number of scans, you have this kind of printout, a GPA analysis, which helps you detect progression. One thing I have to tell you is, when you're using something as a baseline, make sure that the baseline field or scan is good. Here, if you use this as a baseline, you're never going to get a good idea about progression. Now we come to perimetry. Perimetry is one test which across the disease spectrum can be used to detect progression. Now this is one field. If you see, it's an advanced field defect. Very little is left here. So in this patient, you have to create a field which will allow you to monitor it, and that you do it by doing a 10-2. And this is the other eye of the same patient. This very early field defects, it is easier for all the statistical assistance you get is for fields which are early to moderate. When you have an advanced field defect, statistics is of no use. It's you and your gut and the way you have been trained. Yeah. So as I said, that in moderate to early glaucomas, you have the GPA to help you. I'm not going to go into the details of that, but yes. Now this is one patient whom I had seen in 2011 November, and if you see, he has this field defect. He came to me just about a week earlier, and if you see, the field defect has increased. But does it really mean that I jumped to and his pressures have been okay? So you have to take it in the clinical scenario. I repeated the field yesterday. It shows progression, but yet I am not doing anything. So you detect progression, how you act on it is another thing altogether. And the take-home message is, establish a good baseline, repeat tests at periodic intervals is a discipline, take into consideration the sensitivity of the test at which level the glaucoma is, fluctuations are the rule, always repeat and confirm. And thank you for a very patient hearing, and I thank AIOC once again.
Thank you, Dr. Preeti. Indeed, a detailed presentation. Any comments from
Dr. I think Dr. Shweta, you should just put up a presentation, because you only have.
Dr. Subhashini?
You said you want to go. Okay, Dr. Suhasini, please, if you can just load your slides. Any comments on the progression? Progression, look, so there are two aspects of progression quickly before the slides come on. One is perimetry and one would be OCT for all of those of you who have OCT. Again, the OCT, the jury is divided on whether you go for macular GCC for progression or you go for CP-RNFL for progression. And most of the literature says that CP-RNFL is better for progression than macular GCC. However, there are difference of opinion. But on perimetry, once you want to do progression, you have to at least have the same perimeter, 3 fields, and then go for GP analysis. Or if you don't have the same perimeter, then you have to manually actually mark out each point. And 10-2, once the progression has reached 10-2, she is right in saying, what will you do? Then obviously you lower the target pressure. But before doing that, I would just give a very simple caveat. Always ask for adherence issues. Very often the patient is not putting the medication and the progression is because of those issues. So before we go for a further surgery or more drugs, ask for adherence.